Hi, I'm Brent Beasley. I'm the Medical Director for St. Luke's Care, and welcome. Today we're going to be going through sepsis updates. A lot has happened in sepsis over the last few years, and I think it's valuable for us to kind of start looking a little bit at the history of the Surviving Sepsis Campaign, the Surviving Sepsis Campaign 2012 update that recently came out, and looking at sepsis within the St. Luke's health system. So first, a pop quiz. So which of these patients would you say has sepsis? Number one, a 35-year-old male with signs of a sinus infection, has a white blood count of 13,000 and a fever of 102. Number two, a 72-year-old female has a UTI with a respiratory rate of 22 and a heart rate of 95. Number three, a 16-year-old football player with a boil on his leg and a temperature of 100.5, white blood count of 8,000 with 12% bands. Number four, a 56-year-old female with right lower lobe pneumonia has a PCO2 of 31 and a white blood count of 3,000. Number five, a 36-year-old patient with endocarditis who has positive blood cultures, a white blood count of 15,000, and a temperature of 101. Well, the answer to this is all of them. And it's kind of interesting. Let's drop back and take a look at this. The diagnosis of sepsis actually requires systemic inflammatory response syndrome that's positive, and we'll talk a little more about that, as well as a suspicion of an infection. Now, going back to those search criteria, I know that when I was in residency, it's been a while, and it's good to go back and think about what are those search criteria really. Here's the definition that was proposed in 1992. A temperature that's less than 96.8 or greater than 100.4, a heart rate that's greater than 90, a respiratory rate that's greater than 20 or the PaCO2 of less than 32, and a white blood count that's less than 4,000 or greater than 12,000 or 10% bands. And those search criteria have really stayed with us over the years, now for many years, and are important in the way that we begin to recognize sepsis. So looking back at those cases, this 35-year-old male may be in your ambulatory office, maybe in the emergency department with a sinus infection. But here we have a white blood count of 13,000 and a fever of 102, which definitely puts him into a surge criteria being positive, and he's got an infection. That right there means the patient has sepsis, by definition. Now, when I was training, we often didn't think about patients having sepsis unless they were near death in an MICU, on the ventilator. And so it's not the first thing that came to my mind a few years ago when people started saying, I think this patient, who to me just had a simple pneumonia, probably has sepsis. That was really a paradigm shift for me. And it's because the whole issue of sepsis has come out as so highly important for us to catch early through largely the work of the Surviving Sepsis Campaign, which we're going to cover and get to. Going on, this 72-year-old with the respiratory rate of 22 and the heart rate of 95, each one of these criteria that appear on each one of these patients are part of the surge criteria, and I think it's important for us as physicians, and it's important for our nursing staff to know those surge criteria because they're a very important flag that there's a problem in these patients. You know, the one that's the scary one is the 16-year-old football player with a boil on his leg, a temperature of 100.5, and a white count of 8,000 with 12% bands, because you know, that's the one who sometimes gets sent home with some antibiotics, but within, 6 hours could crash at home and have a bad experience. Well, let's move on. One of the things that we begin to see in the national data, and this is from the CDC, this was actually from the last quarter of 2012 in a report in the CDC, and it was talking about in terms of the percentage of hospitalizations that actually end in death. Looking at their first diagnosis that's listed, and look where sepsis falls, the percentage of the patients hospitalized ending in death. So up to 15% in this one last quarter. more than those with heart attack, more than those with cancer, more than those who come in with a stroke. Also, the CDC has also been provided some good data on the patients presenting with sepsis by age. So much more common in patients who are older that are presenting with sepsis. And then the issue about the length of stay of the hospitalization. So these are our sick patients. The patients who come in with sepsis are our sick patients. So let's go through the history of the Surviving Sepsis campaign. It was launched in 2002. It was a collaboration between the European Society of Intensive Care Medicine, the International Sepsis Forum, and the Society of Critical Care Medicine, with an objective: a 25% reduction in relative risk of death from severe sepsis and septic shock through the development and promulgation of evidence-based guidelines. Now, this group, after they set the guidelines up, they began to register patients. And they presented their data in 2010 with 15,000 patients had been registered in the US, in Europe, and South America at 165 different sites. This is a very large database study. Implementing the 2008 Surviving Sepsis Guidelines. So remember, the first set came out in 2002. There have been updates along the way, and in 2008 there were some updates that they used that they wanted to make sure that these patients, these 15,000 patients, had those updates implemented. 80% of the hospitals had more than 250 beds, and in this study they found an overall mortality decrease from 37% in the first quarter of the study to 31% by 2 years. That's a 6% absolute risk reduction, and it was highly significant. A few of the things about the patients we see: first of all, about half the patients came in through an emergency department with sepsis. 13% were recognized with sepsis in a critical care unit, and 35% were recognized with sepsis on one of the general medicine or med-surg floors. And look at the differences in mortality between those. So the ED patients, when you recognize it early, when they first come in the ED, had a lower mortality, whereas the ones that are sitting on our ward units, who then we recognize they have sepsis, they have a 47% mortality. Now, some of that also plays into what causes the sepsis to begin with. So your patients, the vast majority, had pneumonia. And we see that in our hospitals in the St. Luke's Health System as well. 44% with a 38% mortality. The one that's had the highest mortality was abdominal infections, and they had a 41% mortality. Looking at these different parts of the sepsis bundle that the Surviving Sepsis campaign folks have laid out for us, they wanted to say which one of these is the most important, or at least very important, and how often were these hospitals able to achieve these. So looking at them in particular, measuring the lactate, which in some ways is one of the very first things we got to get to, 79% of the patients in this study had their lactate level drawn. Blood cultures before antibiotics, 78% had their blood cultures given or taken before antibiotics were given, and it actually was independently associated with an improvement in survival. Broad spectrum antibiotic use, again, 68% had achieved that. It was independently associated with survival. Getting the CVP, so getting the central venous pressure above 8, only 38% of the patients, only 38% of the patients, yes, had that they achieved that in this study. It was associated with survival, but not as an independent predictor. That doesn't mean it's not an important goal. Glucose control, and they looked at, in this study, they looked at if they were able to keep the glucose less than 150, and 57% of the patients, they were able to achieve that. It was independently associated with improved survival. Using low plateau pressure ventilation when the patients have begun to go into ARDS or that type of thing, 26%, only 26% of the patients had this implemented, but again, it was statistically significantly associated with survival. And here's one of the things that I think we need to think a lot about: achieving all the bundle elements. So all the things we know that we need to do right on a regular basis when a patient comes in with sepsis. Only 26% of the time were these achieved in all the patients, all the bundle elements achieved in the patients. It doesn't tell us in the paper for those 26% how low their survival was compared to the others, but I think we need to be thinking about that issue because I suspect that they did better. The conclusions: the sepsis bundle worked. The longer you used it, the better survival. Imperfect adherence still improved survival. And there was special focus on emergency department, which is the majority of the presentations, and pneumonia having the highest mortality. And once again, going back to the key question I posed to you, what do you think that the survival would be if we actually achieved a 100% adherence to these important survival criteria? Well, let's turn our attention now to something that has a lot of importance that just came out in the last month. This was the Surviving Sepsis Campaign International Guidelines for Management of Severe Sepsis and Septic Shock 2012. And I've adapted these following slides directly from the article that appeared in Critical Care Medicine in 2013. Now, once again, these are the 2012 updates. I've been waiting for them all the way through 2012, and they're finally here, but it came out in 2013. As we go through these, it's also important to remember that these criteria have a grade. And the grade system, the grade recommendation system, classifies recommendations in two ways. First, the quality of evidence, and it gives it a score of A through D, being high to very low. And it also, they classify the recommendations of the group as whether they're very strong recommendations or weaker recommendations. Okay, we're going to get started. This part of this presentation goes from A to Z. It's got a lot of information. We're going to go through it pretty quickly, and it's probably important that each of us take time to review these recommendations in detail, particularly those of us who would be taking care of patients at the bedside in a critical care unit setting. As we go through it, we can also point out the grade from the grade criteria that was given to each one of these recommendations. I think it's important for us to look at those and to recognize the ones that are very strong recommendations and those who have high amount of evidence for their recommendation. All right, here we go. Number one, so initial resuscitation with a protocolized quantitative resuscitation of patients with sepsis-induced tissue hypoperfusion. Hypoperfusion being defined as hypotension persisting after initial fluid challenge or when the blood lactate is more than 4. Now, what they're telling us is the goals during the first 6 hours of resuscitation that are so highly important are A, the CVP being between 8 to 12. And think about that. That means that we need to be able to measure the CVP, which means we need to be able to get some central line exposure in these patients to be able to check that. B, the mean arterial pressure keeping above 65. C, a urine output. And I remember my mentors in residency always saying, you know, if you really want to know how a patient's doing, we got to see what their urine output's doing. Of greater than or equal to 0.5 cc's per kilogram per hour. And D, central venous or mixed venous oxygen saturation of 70% or 65% respectively. Those were a grade 1C. In other words, all those, they felt very strongly that those criteria were important. C being the level of evidence. It was weaker overall level of evidence, so they didn't have strong randomized controlled trials showing these. But when you're doing quality improvement studies, and this is an important caveat, when you're doing quality improvement studies, it's very difficult to do a randomized controlled trial because you are doing it on patients who have not registered in any type of database or registered or signed up for a trial, and you're comparing these patients to see who's doing better. So some of the studies that are used to make these recommendations are from quality improvement studies and they cost an extraordinary amount of money to actually do a randomized controlled trial. So we're going to give them a little bit on that. And then the second, in patients with elevated lactate levels, targeting the resuscitation to normalize the lactate. A weaker recommendation, a weaker evidence level, but it's also a good target for us to think about because it's something we can measure and show we've shut down the process. Now, on each one of these slides, I'm not going to go through them in that much detail, but I did want to point out this issue about what the grade criteria means as we look at these, and I will point out the most important things that are on the list that I think we've got to cover. B, screening for sepsis and performance improvements. So number one, routine screening of potentially infected, seriously ill patients for severe sepsis to allow earlier implementation of therapy. And two, the hospital-based performance improvement efforts in severe sepsis. This was an ungraded recommendation, but it's important for us to go forward to make sure that we are doing what we can at the hospital level to improve efforts in this area. C, diagnosis. Getting cultures as clinically appropriate before antimicrobial therapy if no significant delay is anticipated. So if you think it's going to be 45 minutes before you can get those blood cultures started, you got to get the antibiotics in. But if you can, it's really helpful to get the blood cultures first. And more than 2 sets of blood cultures, both aerobic and anaerobic. One drawn percutaneously and one drawn through each vascular access device. So if they have a PICC line in, for instance, unless the device was recently inserted, which means in the previous 48 hours. And here's a new one that's been becoming more important to us is, if available, an invasive candidiasis is in the differential diagnosis. There's 3 new tests that are out there for us to look for it, and getting those ordered early. I know with some of the sepsis patients that I've taken care of in the past, the cultures come back with candidiasis. You realize we haven't started any type of antifungal, and at that point we're a little bit behind the 8 ball. So these are some new tests that perhaps might help us get the diagnosis of candidiasis earlier. And then third, imaging studies performed promptly to confirm a potential source. In terms of the antimicrobial therapy, I've tried to outline these in terms of rules because I think it's easier for me to remember 4 good main rules. Number one, a 1-hour rule. Getting the administration of effective IV antimicrobials within 1 hour of recognition of septic shock. That's a grade 1B. Strong recommendation and strong evidence. And a severe sepsis, in patients with severe sepsis without septic shock, which would be a grade 1C in those days, as the goal of therapy. Number 2A, I call this a broad spectrum rule. So the initial empiric and anti-infective therapy of 1 or more drugs that have activity against all likely pathogens and that penetrate in adequate concentrations into tissues. And that's, again, a 1B grade. Here's a de-escalation rule. And we're getting to these issues of de-escalation because of all the C. diff that we're seeing in the hospitals, as well as different types of bugs that are developing resistance to our antimicrobial. So we do want to de-escalate antimicrobial therapy as soon as possible. So antimicrobial regimens should be reassessed daily for potential de-escalation. And the procalcitonin rule, which is using a procalcitonin level as a biomarker to assist clinicians in the discontinuation of empiric antibiotics. And this is a grade 2C, and it's interesting, in the St. Luke's Health System, we are now evaluating that, getting it on our pneumonia order sets and seeing what type of difference it makes in our patients. And then there's a combination rule. So this would be a grade 2B, but there's certain patient groups that we definitely have to have combination therapy, and there's some specific combination therapies that are in these guidelines, but they're for neutropenic patients, difficult multi-drug resistant bacteria that's suspected, severe patients with respiratory failure and septic shock, bacteremic strep pneumonia. Here's 4B, empiric combination therapy for no more than 3 to 5 days, de-escalating to a single therapy as soon as possible. 5, duration of therapy, typically 7 to 10 days. And 6, antiviral therapy initiated as soon as possible in patients with a viral origin. E is the source control. So here we have A, a specific anatomical diagnosis of infection and control with within the first 12 hours. You want to figure out where it's coming from, what's the most likely source, and get the patient started on the appropriate antibiotics. So doing the imaging studies, doing things you have to do to figure that out, get it done quickly in the first 12 hours. This is a rush. This is not something you can call in from home. This is really bedside care. Number two, peripancreatic necrosis. Delaying intervention on the peripancreatic necrosis until adequate demarcation of viable and non-viable tissues. That may mean we need to wait a day or two to see where there's the edema and where's the tissue that's necrosed. Number three, intervention with least physiologic insult should be used. So in other words, using percutaneous drainage as opposed to surgical. And four, if intravascular access devices are a possible source, remove them. Now this is something we've gone back and forth in recent years. There's the idea of antimicrobial packing in these devices. Their recommendation, if intravascular access devices are a possible source, remove promptly after you get other vascular access. Once again, we got a lot of fluids going in these folks. We have antibiotics going into them, so we do need to have access, but getting that line out if we think that's a potential source. Infection prevention, 1A. Investigate selective oral decontamination and selective digestive decontamination to reduce the incidence of ventilator-associated pneumonia. That's a grade 2B. And 1B, oral chlorhexidine gluconate be used as a form of oropharyngeal decontamination to reduce the risk of ventilator-associated pneumonia in ICU patients with severe sepsis. So a lot of focus on oral care in this, and I'll give you a heads up. In the most recent New England Journal of Medicine in 2013 that just came out, it's looking at the issue of chlorhexidine bathing daily in the ICU patients and trying to prevent central line infections. So this whole idea about infection prevention in these very sick, critical ill patients is becoming highly important. Fluid therapy for severe sepsis is G. Here's the deal. Crystalloids is the initial fluid of choice. That's a fairly high grade, 1B. No HEPA-starch. That's a grade 1B. Albumin is used now in the fluid resuscitation when patients require substantial amounts of crystalloids. I remember about 15 years ago, the literature was saying we don't know that albumins should be used. Now we're back the other way, and the studies are showing that these patients may do better. We've got a 2C grade on this if we're using albumin in the fluid resuscitation when they're needing a lot of crystalloids. And those are going to be your patients that have a low albumin when they come in. Number 4, initial fluid challenge and sepsis-induced tissue hypoperfusion with suspicion of hypovolemia to achieve a minimum of 30 cc's per kilogram of crystalloids. Now, if you got a 100-kilo person, we're going to be putting in 3 liters pretty quickly. So we want to make sure we get our central lines done as quickly as possible. And again, central lines, we want the CVP as one of our goals. So. Number 5, a fluid challenge, which is administration continued of a fluid challenge as long as there is hemodynamic improvement. So if you're seeing a change in the pulse pressure, if you're seeing stroke volume variation, if the arterial pressure and the heart rate are moving the right direction, continue with that until you see stabilization. H, vasopressor. So vasopressor therapy initially to target a mean arterial pressure of 65. And 2, they've come down to grade 1B. There's some more detailed information about vasopressors we won't go into, but know that those 2 things, vasopressor, if your fluids aren't keeping your pressure up and you're less than a mean arterial pressure of 65, get your vasopressor started and start with norepi. Inotropic therapy, so they gave us some recommendations, a trial of dobutamine in the presence of a low cardiac output or ongoing hypoperfusion or lactate is not staying up, despite achieving, or is not going down, excuse me, despite achieving adequate intravascular volume and adequate mean arterial pressure. That's a grade 1C. And don't try to use that inotropic therapy to increase the cardiac index to supranormal levels. You're only trying to get it up to make sure that they're perfusing well. J is corticosteroids. So don't use steroids if fluid and vasopressor restore hemodynamic stability. And this is interesting. You know, we've gone back and forth again on steroids with sepsis. And there was one time they said give steroids when the patient first comes in, first hits the door, no matter what. There's been a lot of discussion about whether we should be using cortrosine stim tests, things like that. Don't use steroids if the fluid and vasopressor restore hemodynamic stability. If you're not achieving your goal at that point, then give IV hydrocortisone alone at 200 milligrams per day. That's a grade 2C. Don't use the ACTH stim test. Taper your steroids when the vasopressors are no longer required. Corticosteroids should not be administered in the absence of shock. And when hydrocortisone is given, use continuous flow. On to K, blood product administrations. You know, in the last few years, we've been having a lot of information come up about the deleterious effects of transfusions. When I was a resident, I remember we gave everybody blood to keep their blood count up above 8. And we would want to give them 2 units at a time. The different studies that have been coming out lately are showing that patients' length of stay, their survival, other infections, all these things are independently associated with how many transfusions a patient had during the hospitalization. So we have had another CME program that you can watch talking about blood utilization, utilization of blood products in the St. Louis Health System, and our efforts to use them wisely. And so I'm going to refer you to that CME, but know that in these criteria on the blood product administration recommended by the Surviving Sepsis Campaign, they say no red blood cell transfusions unless it's hemoglobin's less than 7, targeting to keep it between 7 and 9. That's a grade 1B, unless you have other issues like hyperperfusion, myocardial ischemia, hypoxia, acute hemorrhage, or ischemic heart disease. Then you might have a little bit of a higher goal. But in general, this recommendation by Surviving Sepsis Campaign matches what we are doing in the St. Luke's Health System with our new initiative on blood products. Number 2, no EPO. They don't find that it's helpful. That's a grade 1B. Number 3, no FFP for abnormal labs. So if you see the protons elevated, we're not called on to give FFP just without any bleeding or any invasive procedures that are planned. Number 4, no antithrombin. And 5, using platelets prophylactically, which is a little bit of a new recommendation. It's a lower grade, grade 2D, but they're thinking ahead in terms of when counts are less than 10,000 in the absence of apparent bleeding. We perhaps should be using prophylactic platelets in those things. Once again, it's not a real strong grade on that. When counts are less than 20,000, if the patient has a significant risk of bleeding, then we might be using platelets. Or if there's higher platelet counts, advised for active bleeding. So if we actually see bleeding, we want to get those platelet counts higher. Okay, LM and N are real quick. IVIG, don't use it. Selenium, don't use it. And drotrecogan, it's not on the market anymore. So if you remember, there's a lot of controversy about that a few years ago, and I'll refer you to the Surviving Sepsis Guideline if you want to read a lot more about that. Oh, mechanical ventilation of sepsis-induced ARDS. This is another highly critical piece. We need to make sure that all of our ICUs in the St. Luke's Health System are adherent to these guidelines because they are important. Remember, we said that these were independently associated with survival in the Surviving Sepsis Campaign study in 2010. So number 1, a tidal volume of 6. When I was a resident, you know, we would put patients on a tidal volumes of 10 to 12 with what we started them on. On these patients, we're concerned about ARDS. We want to make sure we prevent barotrauma. So starting at a tidal volume of 6 milliliters per kilogram of predicted body weight, based on their height, not on their actual fat content of their body. That's a grade 1A recommendation. Number 2, plateau pressures, initial upper limit less than 30. That's a 1B. Adding PEEP, that's a 1B. Higher rather than lower levels of PEEP, that's a 2C recommendation. Using recruitment maneuvers with severe refractory hypoxia. And number 6, prone positioning if our PaO2 to FiO2 ratio is less than 100, and if your site has experience with that type of practice, which we do in our ICUs in the St. Luke's Health System. Going on, keeping the head of the bed 30 to 45 degrees to prevent aspiration or ventilator-associated pneumonia. Number 8, non-invasive mask ventilation in some selected patients. Number 9, weaning protocol with spontaneous breathing trials. That is a 1A recommendation. That ought to be done every day, at least on our patients, giving them a spontaneous breathing trial. We've also called that a sedation vacation. Number 10, no pulmonary artery catheters. 1A recommendation. In the past, we were once again worried about cardiac output with sepsis. They did not find that the pulmonary artery catheters have made a difference. 11, a conservative rather than a liberal fluid strategy if no hyperperfusion. So in the beginning, when we're worried about hypoperfusion, we want to make sure we give fluids a lot and fast. In this stage, when we've stabilized the patient, we've got them on the ventilator, and we're worried about ARDS, we're going to lean towards a conservative fluid strategy instead of liberal. And 12, no beta-2 agonists unless bronchospasm is present. That's a 1B recommendation. P, sedation, analgesia, and neuromuscular blockade in sepsis. Number 1, continuous or intermittent sedation be minimized, targeting specific titration endpoints. That's a grade 1B recommendation, a fairly high recommendation there. Number 2, avoiding neuromuscular blocking agents if possible, if they are required, if you have to use them in these patients with severe ARDS. Use them either intermittent bolus or a continuous infusion with train of 4 monitoring on the cheek. And 3, a short course of NMBA of less than 48 hours for patients with early sepsis-induced ARDS and a PaO2 to FiO2 ratio of less than 150, and that's a grade 2C. So still a lot of controversy on neuromuscular blockade in sepsis patients and how much good does it do. Q, glucose control. The controversy on glucose control is not about whether it makes a difference. The controversy has to do at what levels are we shooting for, and I'll talk a little bit about that. But into the guidelines, number 1, a protocolized approach to blood glucose management, commencing insulin when 2 consecutive blood glucose levels are more than 180. And this protocolized approach in this guideline, it says, should target an upper blood glucose less than 180 rather than an upper target blood glucose of less than 110, and that was grade 1A. Now, to talk specifically a little bit about that, in patients in MICU settings, there was a study looking at very tight control of glucose, and there was some concern that hypoglycemia, so when you're really aggressive, you get some hypoglycemia, that hypoglycemia may worsen our outcomes. And so there's a caution in this about driving down and creating too much hypoglycemia. I'm going to refer you to this controversy to our St. Luke's CME on intensive glucose therapy with Dr. Mikhail Kosibroid, because he puts together a very nice explanation of the literature in this area and why it's important for us to know about. In the St. Luke's Health System, we have been looking at trying to get our goals lower than 140. And in this guideline, it talks about less than 180. It says definitely not less than 110, and I think we're in agreement on that. In our health system, we have a lot of experience with using these protocolized approaches, and we are monitoring and trying to prevent hypoglycemia. So I think there's still a lot of areas that are going to be changing in this area over the next few years as some of these other large studies are completed. There's other large studies that are looking at this issue right now. And once again, I think we have a fairly good CME that explores this topic in a lot more depth that I'll refer you to. Number 2, blood glucose monitored every 1 to 2 hours until the glucose and the insulin infusion rates are stable, then every 4 hours. And 3, interpret the glucose point-of-care testing with caution because it may not be accurate in sepsis. So just checking a finger stick may not always be accurate. Getting that venous stick may also be a good way to see are we getting good correlation between the two, at least once or twice during the hospitalization. R, renal replacement therapy. So a lot of our patients with severe sepsis wind up not only on the ventilator, but requiring some renal replacement therapy. So the first one, continuous renal replacement therapies and intermittent hemodialysis are equivalent. From what some of the studies are showing us, is there a benefit from one over the other? It may be equivalent. And number 2, use continuous therapies to facilitate management of fluid balance in hemodynamically unstable septic patients. And that's where it really helps to have the continuous renal replacement therapy is when you're really worried about fluid balance. You're really worried about are we getting too low or are we too high? S, bicarbonate therapy. Again, here's another guideline that says nothing. No bicarbonate therapy for hypoperfusion-induced lactic acidemia with a pH of more than 7.15. In general, the studies aren't showing that bicarbonate does a whole lot of good. T, DVT prophylaxis. So daily pharmacoprophylaxis against venous thromboembolism gets a grade 1B, and we think it's highly important. Second, combination of pharmacologic therapy and intermittent pneumatic compression devices whenever possible. And 3, if there's a contraindication for heparin use the graduated compression stockings or intermittent compression devices unless they're contraindicated. And when the risk decreases, start the pharmacoprophylaxis. V is nutrition. So there's a lot of emphasis in this guideline, and the grade is a little lower. It's more of a weak recommendation. So these are grade 2, but that you look towards oral and enteral feedings within the first 48 hours. Number 2, suggesting low-dose feeding the first week. So in other words, don't give them a whole lot of calories. They're recommending less than 500 calories per day, but that we do get it started that first week, and then advancing as tolerated. Number 3, using IV glucose and enteral nutrition rather than TPN in the first 7 days after a diagnosis of severe sepsis and septic shock. And that's a grade 2B again. And number 4, using nutrition with no specific immunomodulating supplementation. And that's a grade 2C. There's really not any good evidence, and it's a very weak recommendation. Setting our goals of care. Number 1, discussing goals of care and the prognosis with patients and their family. You know, I think one of the most important things that I can do, particularly as a primary care physician, when my patient comes into the hospital, is, if it's someone I know, to be there, to talk to the family and help them understand, you know, this is a setting of high mortality. What are the patient's life goals at this point? We see a lot of patients sometimes coming from a nursing home who maybe have end-stage dementia, presenting with urosepsis in the emergency room. Perhaps their family is not available when they come in the middle of the night. It's highly important to have that discussion with the family. What would this patient want done in this situation now? You know the patient well as a family member. You know what they would want done. We need to do what they would want to have happen in a situation like that. Because we are spending this is editorial, we're expending an extraordinary number of resources nationwide on end-of-life care, and a lot of these end-of-life care situations are patients with sepsis. The older gentleman who comes in with pneumonia after the flu, who once again has been in a nursing home, is fairly ill, has multiple comorbidities, and they're coming in with sepsis. Or the little old lady that's got end-stage Alzheimer's, as I mentioned, who's coming in with a urosepsis. These are fairly common occurrences within all the health systems in the United States, and it's up to us as the doctors, as the primary care doctors, as well as the hospitals, as well as the critical care specialists, to take that time, sit down with the family and the patient, and determine what would they want in a situation like this. Would they want us to make them comfortable, make sure the last few days are comfortable? Would they want us to do everything? Those type of conversations are difficult, but they're critical. And this was a high grade 1B recommendation. Number 2, incorporating goals of care into treatment and end-of-life care planning, utilizing palliative care principles where appropriate. And 3, addressing goals of care as early as feasible, but no later than within 72 hours of an ICU admission. And I want to come back and stress, I think it needs to be within the first 12 hours. It needs to be when we were first figuring out what we're going to do with this patient in the emergency room, if possible. X, Y, and Z. They didn't label these as X, Y, and Z, but since they had gone from A through W, I thought they would be valuable to go through with X, Y, and Z. The bundles and targets. So to be completed, so this is right out of the guidelines, to be completed within 3 hours, number 1, measure that lactate level. Number 2, obtain the blood cultures prior to the administration of antibiotics. Number 3, administer broad-spectrum antibiotics. Number 4, administer 30 cc's per kilo of crystalloid for hypotension or lactic acidosis with that lactate level more than 4. And the second targets are those to be completed within 6 hours. Number 5, apply vasopressors to maintain the MAP more than 65. 6, for persistent hypotension or a lactate level that's high, measure that CVP and set that target at 8 to 12. Measure the SCVO2 and your targeting there is more than 70%. And finally, 7, remeasure the lactate if the initial lactate level was elevated. Well, right now we're going to turn our attention to what's going on in the St. Luke's health system. We've looked at the past with sepsis survival. We've looked at the current new guidelines that come out. Now we're moving on to what's going on here on the ground. And we've had a lot of activity in sepsis over the last 2 years. So let me take you through a little bit about that. We have had sepsis PI projects in different St. Luke's Health System hospitals on different floors and ICUs and by different groups for many years. We have not had system standard processes defined by who, what, where, when, why, and how for, number 1, the rapid recognition of SIRS, and we went through what the SIRS criteria were already. Number 2, the rapid diagnosis of sepsis. Number 3, the assessment of the severity of sepsis, that's highly critical. Number 4, the timely and effective treatment of sepsis. We are looking at how often are we diagnosing sepsis. So we're looking at the number of codes that come through with a sepsis code. We're looking at also other ways of diagnosing sepsis in coding when we see organ system dysfunction and an infection code at the same time. There's literature to suggest if there's 2 organs dysfunctioning and an infection code at the same time, it's highly likely that particular patient has sepsis. So we're trying to track in the St. Luke's Health System which patients have sepsis, different ways. And then we're also looking at mortality. Now, one of the things that I mentioned, and I'll point out real quickly, in the Surviving Sepsis campaign, all those patients in all those hospitals, at the end of the Surviving Sepsis campaign study, they had a mortality rate of 30%. They had dropped it 6% absolute drop in the absolute relative risk of 6 percentage points from 37% down to 31%. So starting with a 30% mortality may sound scary, but that's actually the best that the Surviving Sepsis campaign got to. We think we can do better, and we think we are already doing better. So what I've shown you already is some data from the St. Luke's Health System. That's some older data. We know that this year, in 2012, we're already seeing our mortality rate getting down around 20%. We know from other health systems that we can go lower than that because we've seen some other health systems present data that shows that they've got lower mortality rates in certain areas. For instance, as I told you, the Surviving Sepsis campaign, patients in the emergency department, entering through the emergency department with sepsis, had a lower mortality. There's ways that you can set up processes within the health system, within your within each department to slick the way, just like butter, to make sure that the blood culture is done, the antibiotics are done, the lactate level is drawn, the fluid is given quickly, the patient's resuscitated very quickly, that drive down that mortality. And that's been shown in studies. We've seen it in other people's quality data, and we are implementing that in the St. Luke's Health System. I'm going to tell you about what we've done this year to implement that. Just as a note, how much is the St. Luke's Health System spending on sepsis patients? So for the 1,187 patients that we identified with sepsis, the cost was about $43 million. So this is a large cost area, and it's really important that we manage this area well because of the high mortality, because of the high morbidity, but also because we have to make sure we manage our costs well on a very expensive area. These patients are costing anywhere from $15,000 to $40,000 during their admission. And the length of stay, as we've seen in previous studies, is high, an average of 11.4 days back in 2011 when we looked at some older data. The cost, as I said, was fairly high, on average $36,000 a patient. One of our concerns back in 2011 when we looked at this, and this is already once again improved with the different things that we've been working on, is utilization of a sepsis screen at the time was fairly low. We had certain floors, certain hospitals that were focused on it, but as a system, we were fairly low on using our sepsis screening tool. So there was actually a paper sepsis screening tool that St. Luke's Care had developed, and it really didn't have the uptake right at first that we wanted. The severe sepsis order set was only being used 3 to 25% of the time, depending once again on the floor, depending on the hospital. So let me take you real quickly through the leverage points in this whole sepsis flow. When we first have a patient presenting, that issue of recognizing SIRS is a major leverage point. Very few things happen very quickly unless we recognize SIRS early. Then we got to ask ourselves, is there evidence of infection? If the answer is yes, and once again, only a physician can diagnose an infection. If the answer is yes, the diagnosis then is sepsis. And at that point, we need to make sure we are drawing the lactic acid level. That's another leverage point, a high importance leverage point. Is the lactate level elevated, or are there two organs that are dysfunctioning? If that's the case, then we are into the severe sepsis. That's another leverage point. We have to figure out how to do that well. And then finally, as we work through the flow, asking ourselves, is the patient in shock? Then they're in severe sepsis with shock. That's the diagnosis. We need to start down at the bottom, early goal-directed therapy, and we have that 6-hour window we've talked about before, and we need to get our sepsis order sets started, and we need to get the patients transferred to the ICU. That's another highly important leverage point for us to focus on. So what we did in the fall was come out with the Sepsis Summit. So we brought together leaders of our organization into the same room, 40 folks. We had 5 physicians. We had nurses from the ED, from med-surg floors, and critical care units. We divided these folks up into teams. And so we have our Sepsis Summit ED team that was around a table. We see Mark Larson, one of our ED doctors, with his head down at the table looking over data. Our Sepsis Summit med-surg team. And so we had the group that's gathered around thinking about the med-surg areas and how do we do sepsis well there. Our critical care team looking at what should be happening in the critical care units. It was a loud room that day when we had all these people there working on this, and we spent a whole afternoon in this room. And one of the things we focused on was mapping swim lanes about what should happen within our health system to meet these leverage points. How do we make sure they happen smoothly? How do we make sure they happen wisely within the way that our health system works? here's a editorial point. For other health systems, they may have processes, they may have physician groups and nursing groups that look very different than ours. So anytime we do a quality improvement initiative, we need to make sure that we take what's important and figure out how to operationalize it within our health system. So that's what we focused on with these swim lanes, was trying to operationalize the best practice. So resulting changes from our sepsis summit was to begin screening all ED patients before admission to the hospital and begin screening all floor and ICU patients each shift. So you remember in the guidelines, in the sepsis guidelines, that was one of the high priority items. It was B. It was on our alphabet of A to Z. It was B. If you wanted to go back and look at those slides, where it talks about making sure you've protocolized these interventions and that you use screening for sepsis in these areas. And so we are making sure that it happens. Our physicians then are prompted by the nurse when a SIRS screen is positive to diagnose if sepsis or not. So once again, doctor, is there an infection? If there is an infection, it is sepsis. Ordering the lactate and differentiate routine versus severe sepsis. And so we want to get that first lab being the lactic acid level. There's going to be some other labs you want to make sure we're getting, including once we've got sepsis aboard, we want to get blood cultures. We want to give them start an antibiotic. But that all is required the physician. The nurse is responsible for doing the SIRS screening, and then they bring it to the physician and prompt the physician for these things. And lastly is using the appropriate order sets. Another thing that came out of the Sepsis Summit was we had an area that we did not have a good protocol for, and that is the non-ICU floor patients. And remember back in the data we looked at, those patients who were recognized on the floor actually had a higher mortality than the patients who came through the ED. So it's very important we get the floor patients right. When a nurse is screening for SIRS, for systemic inflammatory response syndrome, and we see that there's a change, and all of a sudden the patient has gone from having a heart rate in the 80s, now their heart rate's up 95 to 100. We know they've already got a fever. We know they've got an infection. At that point, they're on the floor. What do we do? And do they need to go to the ICU? If they've just got routine sepsis, they're not severe sepsis, they're not septic shock, we can probably keep that patient on the floor, treat them on the floor, but we got to make sure that, number one, we get the cultures, the antibiotics started that are appropriate in that situation, because now we've moved from an infection to an infection with sepsis. And then the other thing is the heightened surveillance of our septic patients, because they could crash on us at any time and need to go to the ICU. And so getting that non-ICU floor routine sepsis order set we found is to be very important. And finally, updating all of our screening forms and severe sepsis order sets based on the new guidelines. So these processes have been rolled out system-wide as of March 2013. We are doing competency education for nurses system-wide about sepsis. We are communicating to our physician groups about sepsis and changes to these order sets. Well, our next steps at this point, we want to track sepsis diagnosis. Here's a couple issues about sepsis diagnosis. As we begin to accurately diagnose sepsis on patients who've been sick, who have infections, and in the past weren't diagnosed as sepsis, we're going to see the diagnosis increase. So some of this is a recognition phenomenon rather than we are going to have more sepsis in our health system. We're actually going to be recognizing it more. It was already there. Now we're recognizing it more. The other part of the coding appropriateness is we're able to, on external comparisons with other health systems, see now we've got this group of septic patients that we've actually recognized. We'll be able to make sure that we are evaluated against other people and other benchmarks more appropriately on that group of patients. So when we're looking at things like mortality, when we're looking at things like length of stay, we'll have better accurate benchmarks with other health systems and national benchmarks if we're coding properly. And then the final part about the coding properly is if a patient comes in with pneumonia, it's one codable, billable encounter, but it's a higher billable encounter if they actually have sepsis. So we don't want to leave, in other words, we don't want to leave money on the table in the whole field of medicine nationwide. Every health system is concerned about this, that we code appropriately on our really sick patients so that we get paid for doing the high-level, intense care that we do. We're also going to be tracking the utilization of our sepsis screening forms and the nurses screening in the ED and on the floors. We'll be tracking the utilization of the physician's implementation of sepsis order sets and the sepsis bundles. We're going to launch another sepsis summit in 2013 to reconvene teams to look at where do we need to go from here, and at that point begin rapid cycle improvement based on the data that we're able to come up with. Well, I really thank you for taking time to go through this with us today. I think it's highly important. I think it's an area in our health system that we need to spend some time thinking about. We need to spend some time with our patients doing the right thing. We need to educate ourselves on what the most current criteria for sepsis are, what the most current guidelines for sepsis are, and make sure that we are doing our best to treat them by those. I know that our EICU doctors, they're available at any time if you want to give them a phone call, if you have questions about sepsis. We also have our critical care specialists in each of our ICUs that are there and available if we have questions. When the patient's on the floor, if we're concerned about whether they need to be transferred to the ICU, they want to hear for us because they want to get that the severe sepsis and septic shock orders implemented as soon as possible. You know, the very best way that we can improve medical care in any health system and in our health system is communication with each other as physicians, as the whole team, including the nurses, the IAs, the respiratory therapists, all of us talking to each other. Picking up a phone is the cheapest way, I think, to improve medical care around. And so I encourage us to be talking about these very sick and patients who potentially have a very high mortality, talking about them with our colleagues often and making sure that we're all on the same page. Thank you very much for taking time today. If you have further questions, don't hesitate to email me. Don't hesitate to give our EICU doctor a call. They're standing by for your call. Thank you very much. Have a nice day.